Good morning. I'm Najia Uzair from the Department of Pediatric Ophthalmology, Al Shifa Trust Eye Hospital, Rawalpindi, Pakistan. So I have a few interesting cases of pediatric phakomatosis. The first case is a 6-year-old boy who presented with a history of fits since the age of 3 years. He had these multiple brownish lesions over his face. Fundus examination revealed this white, translucent, slightly elevated lesion, which was about a disc diameter. It was at the macula, but it was not involving the fovea. Fundus autofluorescence revealed that there was not just one lesion, but actually 3 such lesions in the right eye. OCT macula through one of the lesions revealed that this lesion was originating from the nerve fiber layer, and there were optically empty spaces and shadowing within the lesion. These findings were characteristics of retinal astrocytomas. Fundus examination of the other eye revealed similar looking lesions. This child also had some irregular plaques on the skin of his lumbar region, a few nail deformities, and MRI was done for the fits, which revealed multiple cortical tubers which were hyperintense. So we put together all these findings of the adenoma sebaceum, the shagreen patch, the ungul fibromas, and the cerebral cortex tubers with these characteristic retinal astrocytomas and got to a diagnosis of, can somebody tell me? Tuberous sclerosis, exactly. So this patient is very well controlled on antiepileptics. And as for the retinal astrocytomas, we are observing him because there have been reports that these retinal astrocytomas can break through the ILM and present with the subretinal or bleeds and vitreous bleeds. So our case 2 is this pleasant looking girl, a 6-year-old girl who presented with bilateral, gradually progressive decreased vision in both her eyes, more in the left as compared to the right, for about 1.5 years. She also had complaints of an outward deviation of the left eye for about 1 year. Visual acuity in the right was 620 and in the left it was counting fingers. Fundus examination revealed bilateral elevated macular pathologies. It was more pronounced, they were more pronounced in the left eye, and you can see here on this multicolored OCT image that this green reflectance indicates that the lesion is elevated above the surface of the retina. So OCT macula revealed bilateral retinal thickening, an ERM with vitreomacular traction, and a central foveal thickness of about 700 microns. So these findings were characteristic for combined hamartomas of the retina and RPE. Orthoptic assessment revealed a left eye exotropia. Pupil in the left eye was fixed and dilated, as you can note here in this picture. There was no fixation of the left eye on covering the right eye. And there was also subtle ptosis, as you can see here in this picture. Extraocular movements revealed limited elevation, limited adduction, and limited depression. Gaze towards the left was normal. So these findings were characteristic, were suggestive of a left third nerve palsy. So we proceeded to refer the patient to a radiologist for neuroimaging, and it revealed a left oculomotor nerve schwannoma. And an incidental finding was a bilateral acoustic neuromas, more on the right side as compared to the left. It was incidental because there were no neurological findings on the right side. And another incidental finding was that this acoustic neuroma was compressing and encasing the right internal carotid artery and the right internal jugular vein, and it was reported by the radiologist to be a life-threatening pathology. So we put together these findings of the left oculomotor nerve schwannoma, the bilateral acoustic neuromas, the neurological manifestations, and the combined hamartomas of the retina and RPE, and got to a diagnosis of NF2, exactly, neurofibromatosis type 2. So this patient is under a multidisciplinary management, and it has been about 8 months since she underwent gamma knife radiosurgery for the right life-threatening acoustic neuroma. And she had mild bilateral conduction deficits on ENT examination. As for the bilateral combined hamartomas, we are just observing them because the parents have not yet consented for surgery. The left squint is dated for correction. So my last case is a healthy, athletic 11-year-old boy who presented with sudden decrease of vision in the right eye. Visual acuity in the right eye at presentation was 636. Anterior segment examination was unremarkable. Fundus examination revealed this huge looped tortuous vessel arising from the disc going up to the macula. And as you can see here in this picture, there were also some hemorrhages along the supratemporal and infratemporal vascular arcades. So we got to a diagnosis of racemose hemangioma with a central retinal venous occlusion. This is the FFA of the patient. This is the OCT macula showing significant subretinal fluid, decreased with the 3 intravitreal anti-VEGF agents, with visual acuity improving to 612. So, and we performed an MRI to rule out vibrant Mason syndrome. These are some pictures from our recent trip to a conference, and thank you very much.